Hey guys, 6 o'clock, Facebook, going live, talking about ventilators and all that good stuff. I'll also be making an announcement at the end, so I'll give guys a few minutes to jump on. My name is Amanda Kay. I'm a CRNA. I don't know if you guys saw yesterday was part 1, and this is the final part 2 of a live learning series I'm doing to start, teaching you guys some things and helping you guys get your mind right and all that good stuff. So, did not get any sleep last night. I don't know if we have any mothers out there listening, but did not sleep last night. You kind of learn to live sleep deprived. And when you're in anesthesia school and when you have kids, I'm sure you feel like how I feel right now, right? You just have to keep going. So I did just get back from a massage. So if my makeup's everywhere, that's why. But anyways, I'm really happy to be doing this. I'm happy to be here. If you guys, hello, welcome. If you missed me yesterday, I talked about kind of getting your mind right and everything like that. I will have a replay up of that, and I will also have a replay up of this as well. So you'll be able to see it if you can't stay or get busy or whatever. I know it's, dinner time for some people. If you did not get the PDF, go ahead and sign up in the link. There is a little PDF that goes with the talk today. So if you signed up, you should have that in your inbox to use for today. It's really short, just to kind of write some notes on. If not, you can just write notes on a regular piece of paper or whatever. All right. So if you're here, I'd love for you to tell me if you're a CRNA, if you're an SRNA or if you are an RN. I've been a CRNA for about 3-4 years now, and I was a trauma nurse before that, so good stuff. All right, let me get stuff ready here. So the reason I wanted to do this today is I've always been so super passionate about helping people, which is why I'm a nurse. But I also love teaching. School was really difficult for me, as I'm sure it is for all of you. And so I want to be here to help you guys and show you guys that it's doable. And no matter where you are at, I want to, inspire you guys and motivate you that you can do this. Even if you're not in school yet, or you're just starting, or you're getting towards the end, don't give up. Believe in yourself and keep going. It's a really hard journey, but it's definitely worth it. I'm also pretty good at taking large chunks of information and making it usable. So that's what I want to do here for you today, is kind of break stuff down. I always felt like the school lectures were just kind of heavy. I didn't like being read to off the slides. Then you always had all these different articles and sources and things you had to read, and I always felt like I was drowning and I just couldn't get ahead. So I want to give you guys some no fluff stuff, the need to know stuff, so you can look awesome at clinical, apply it, understand it, and just keep putting one foot in front of the other and just keep going. All right. So let's go ahead and dive right on in. Excuse me. If you have your PDF, you can go to the second page, which is called the basics, and we're going to go ahead and get started right there. All right. So super, super basic stuff that you all know. Spontaneous ventilation, obviously what we're doing right now. As we're sucking in air, we're creating a negative pressure between our lungs and the interpleural space. When you do mechanical ventilation or positive pressure ventilation, you're blowing air into the patient's lungs to ventilate them during surgery, right? In order to ventilate patients, you have to manipulate 3 things: flows, pressure, and volumes. You have to manipulate those variables. You have to work with those variables in order to provide good ventilation for your patients, in order to overcome any type of resistance and any compliance issues as well. So let's go ahead and define those 3 words really quick to kind of set the stage for what we're going to talk about. We're going to go through vent settings, vent modes, and then I'll put a scenario up to kind of, bring it all home so you guys can understand it. So whenever you're ventilating someone, there's always going to be two factors influencing your ventilation. First one is the patient factors. What is their medical history? Do they have COPD? Are they a heavy smoker? Do they have a lot of secretions? Are they obese? And the second factor is going to be your equipment. So your circuit, your breathing circuit from the anesthesia machine to your patient, your ET tube, your LMA. So all of those things are those are the two factors you're going to be thinking about whenever you start ventilating somebody. So compliance. So all compliance is how far can something stretch? So how far can the lung stretch? That's all compliance is. Desensibility. It has to do with the volume and the airway pressure. So when you take a deep breath in, the compliance is how far those lungs can stretch out. Now, what affects lung and chest wall compliance? Once again, the surgical position can affect it. You can have patients prone, lateral, sitting up, supine. Any type of bronchospasm, pulmonary edema, obesity, ascites, any of those conditions will also affect your compliance, as well as your ET tube. And whenever you do any type of laparoscopic surgery, the surgeon creates a pneumoperitoneum, which is filling the abdomen with CO2, and that's going to put pressure and decrease your compliance as well in the lungs. The second thing to define there is resistance. So what potentially could be holding us back from ventilating that patient, right? Like what's resisting you? What's in the way? And that has to do with your driving pressures and your flow rate. So some examples of things that can cause resistance, once again, bronchospasm, any type of secretions, patients with COPD or asthma, that obstructive type of diagnoses, if your ET tube is kinked, and the breathing circuit. Okay, so that's resistance. And the third thing is elasticity or elastic recoil. So we said compliance was like how far out something can stretch. The elasticity is the ability of that lung to go back to its original form. And elasticity is actually inversely proportional to your compliance. Okay, makes sense? Hi guys, a couple more of you jumped in. We just went ahead and got started. We're on the first page, the basics of the PDF. So hopefully you guys signed up with the link and got your PDF. If not, I can get it to you, but feel free to take some notes. All right. So FRC, huge question I was asked in clinical all the time, functional residual capacity. What this is this is the reserve. So this is the lung reserve. This is what's left after a normal expiratory breath, okay? So I want to talk about whenever we put someone under anesthesia, and as far as the pulmonary system, what are three things that happen? The first one is that our FRC is going to be decreased, right? We're going to lose that. And we're going to talk about what happens when we decrease our FRC in a second. The second thing is we're going to increase resistance by the breathing circuit and our tubes and maybe some patient factors. And the third thing is when patients are under anesthesia, they have a high risk for atelectasis, so collapsing of those alveoli, all right? My program director always had this little cute analogy that I always liked of you have your alveoli here, and then you have a little car with four seats, and as it drives by, it's dropping off CO2, and then it's picking up oxygen from the alveoli, and that's obviously the capillary exchange that we need the lungs to do in order to keep our patients safe under anesthesia. We will talk about some alveolar recruitment, so when those alveoli do collapse, I will teach you some ways that you can recruit those alveoli to pop back up and exchange that O2 and CO2. So, and I don't know if you guys follow me on Instagram or not, but on Instagram, I asked a question about what lung capacity are we filling up when we denitrogenate somebody. So I don't know where you guys are at in clinical, so feel free to write a comment in, tell me if you're an RN, an SRNA, where you're at. But before we put any patient to sleep, we pre-oxygenate them, okay? Or denitrogenate them. So right now we're breathing oxygen and nitrogen, right? So we have oxygen and nitrogen sitting in our FRC and our reserve. When we put someone to sleep, we want to fill that reserve up with oxygen so that if anything were to happen, we have a nice kind of safety net. So we knock out all the nitrogen and fill the FRC up with oxygen. So that's pre-oxygenation. Situations in which this FRC can be decreased and your patient is at a risk of hypoxia or hypoxemia is being pregnant, being in a lithotomy position because you lose like real estate here, ARDS. So if you put a 9-month pregnant person to sleep, they have the risk of desatting super, super fast. Hi, Janae, you're an RN. Hi, nice to have you here. They have a risk to drop those sats, all right, because they have a smaller FRC, right? So when we have patients under anesthesia, we want to maximize their FRC to decrease the risk of atelectasis, okay? Some ways you can do to improve FRC is sit the head of the bed up before you put them to sleep, and when you wake them up, that helps. And you can also throw on some PEEP, which is some positive end expiratory pressure as well. All right. So those are kind of the basics. I wanted to kind of lay the framework out of what we're talking about. And now I want to go into like the ventilator controls. So a lot of you are ICU nurses. Your patients are lying flat in a bed, intubated, right? You do your oral cares, RT comes in, messes with the vent, etc. Hey, Megan. Oh, my girl, congratulations. You could actually probably teach this stuff. You're getting to graduation day. That's awesome. So anyways, you're used to these patients just laying there, right? Now, being the anesthetist at the head of the bed, ventilating patients and, putting them on the ventilator, you have to deal with surgeon factors, the surgical factors, positioning factors, their medical history, et cetera, et cetera. So it's a little bit of a different game, and that's what I want to empower you to kind of learn and do today and give you some of my tips and tricks I use. And this is the part where we get to manage, like we said earlier, the volumes, the flows, and the pressures. So let's say we're on page 2 of the PDF, if you guys have it. So you put your patient to sleep, you intubated them, you didn't hit their teeth or their lips or anything like that. You got your tube in. So now what do we do? So now we need to ventilate them because they're probably paralyzed. So there's 4 controls that you are going to be setting. Your first one is going to be your tidal volume, which I like to use 7 mils per kg. Your second one is your respiratory rate, so about 8 to 12 a minute. Your third one is PEEP. I usually use about 4 to 5 centimeters of water of PEEP. And the last one is your FiO2. So do you want them on 100% oxygen, or do you going to run them, with a little bit of air or with a little bit of nitrous oxide? So those are the 4 things you set: tidal volume, respiratory rate, PEEP, and FiO2, right? So after you do that, you start cleaning up your workspace, hanging out, getting organized, getting ready for the case. Now, what do you have to watch for? Now, what are you going to be watching for to ensure that you are ventilating your patient properly? The first thing is end tidal CO2. I do give on Instagram, I have a Thrive in 5. Every Thursday, I post 5-minute videos on a teaching. I think a couple weeks ago, I did end tidal CO2. So feel free to check that out. I went into some scenarios there, so I'm not going to do it all here. But end tidal CO2 can tell you so much. Ventilation status, perfusion status, that's your number one thing you want to watch for. The second thing is your alveolar or your minute ventilation. And your third one is your peak pressure. So those are the 3 things you want to watch for after you set your controls. So a couple notes about end tidal. Normal is about 35 to 45 millimeters of mercury. You don't ever want it to get too high, like in the 60s, because then your patient can actually fall back asleep, and it's just not good. It can cause, hypertension, and think of patients with OSA. We never want the CO2 to be too high. It is good to use during emergence when you're waking your patient up, because if your CO2 does get high, it stimulates patients to breathe. So it's good to use for that. And then you don't want it too low either. If it's too low, you might be worried about some type of perfusion problem. So I like to keep my end tidal CO2 at probably about like 30, 35, somewhere in there during a case. So peak pressure, I don't know about you guys in the ICU if you're there, I never really mess much with peak pressure. It also can be called PIP, peak inspiratory pressure, or PAP, PEEP airway pressure. And what this is that's a total pressure that's needed to overcome the resistance of your circuit, your ET tube, and anything going on with the patients, okay? And we're going to look at a scenario here at the end and tie all this stuff in together, okay? Are you guys doing okay? Is everything making sense? You can just give me a thumbs up, or do you guys have any questions so far? I'm trying to be as succinct as possible. Are y'all good? Okay. So if you have your PDF, we'll go to the 3rd page. I want to talk. Hey, Clifford, how are you? I want to talk now about about the vent settings and how I choose what, and then we'll do our scenario and tie it all together nicely. Oh, thanks, Megan. You're great. All right. Thanks, guys. My sleep deprived self. All right. So the first vent setting that I use, this is like my go-to for pretty much everything as far as, putting an ET tube in, is volume control. So volume control, you're going to set your tidal volume in mils, and your tidal volume is going to be pretty constant. If you set it at about 500, guess what? It's going to be, 498, 515, something in there. So you're going to have a very solid, stable tidal volume. However, your peak pressure under volume control has a potential to go up and down. So you do need to watch your peak pressures, especially in patients who are pregnant, who are obese, who have COPD, on and on and on. The second one is, I don't know, has anyone, those of you that are in clinicals, have you guys used volume control AF or autoflow? Because I love this one. It's only on the new dragger machine. So I only can use it when I'm at certain facilities. But what it is it's great for laparoscopic surgery, great for any type of T-Berg positioning, prone cases, for obese people, etc. But what it does is it delivers the tidal volume you want at the lowest pressure possible. And if it runs into any resistance or any compliance changes, it's going to gradually increase that pressure. So you're not going to get those high peaks with pressure that you sometimes get with regular volume control. So volume control AF, talk to your preceptors about it, make yourself look good. That's one of my favorite ones to use when I have a dragger machine that has it. The third one is pressure control. I don't tend to use pressure control a lot, and I'll give you an example and tell you why. But pressure control, you set the pressure in centimeters of water, and that's going to dictate your tidal volume. So now you have a stable pressure, but you have a tidal volume that's going to be kind of all over the place. Pressure control is great to use for LMAs. It's also great to use in some type of laparoscopic surgery situations. So you can also use it if you guys have done any pediatric rotations. If you use a ET tube with no cuff, sometimes you have to use pressure control in order to get enough pressure to ventilate, because you have no cuff, securing off the tube from the outside air. All right. So why I don't like to use pressure control a lot. So say you have a patient under getting laparoscopic surgery, right? You throw them on pressure control, or you throw them on volume control, and your peak pressures are like 38, 40. And you're like, oh God, that sucks. Like, what am I going to do? So, okay, fine. I'll put them on pressure control. You change your patient over to pressure control at a pressure of maybe like 30 centimeters of water. Everything's great. Your pressures are right around 30. You're chilling. You're fine. So all of a sudden, the surgeon decreases the pneumoperitoneum. You're drawing up your reversals to reverse your paralytic. You're getting ready to wake up. You're grabbing your Toradol, etc. All of a sudden, you look over and your tidal volumes are like 1,200, 1,300, 1,500. So this is why you didn't, because you didn't change your pressure. So this is why I don't like to use pressure control, because the tidal volumes are so variable with it. So you really have to keep a very close eye when you're using pressure control to see what the surgeon is doing, what's happening on the field, etc. So I tend to not use it a lot. I don't know anybody. I know Clifford, Megan, you guys are in clinical. Do you guys use pressure control a lot? I usually don't. And then PSV, which is pressure support, is like my favorite. There's PSV, and then there's also PSV Pro. So I love it. I like to make the analogy, Clifford, yes. So you use pressure control. What about you, Megan? I just think volume control is easier if I can maintain it. Yep, Megan said that exact thing happened to me. Only on kiddos. Yep. Look at you guys. You guys are awesome. Yep. Same for me. So now pressure support is my total fave. I like to think of this as like your patient's breathing already on their own, and all pressure support is like a nice, good bra. It's like supporting what's already there, right? So pressure support is great when you're waking patients up. You can get them back breathing, and then you can put them on a little bit of pressure support in order to, help continue the anesthetic and keep their tidal volumes up. So what happens, my smart SRNAs out there, what happens to your tidal volumes and your respiratory rate when your patient's under anesthesia? Anybody know? Do they go up, down? Anybody? And this is why pressure support is so good to use. So I got asked this all the time when I was in clinical. So when you have a patient under anesthesia, your tidal volumes are going to go down, yep, and your respiratory rate is actually going to go up. Hello, how are you? Nice to see you. So yeah, so under anesthesia, tidal volumes down, respiratory rate goes up. So automatically, whenever you have someone asleep and they're spontaneously breathing, you automatically want to put them on some pressure support in order to keep those tidal volumes up and in order to keep your end tidal CO2 from getting too down. Yes, fast and shallow. You're totally right. Yep. You guys will see too, when you're in clinical, you have somebody in anesthesia and they'll be breathing 20 a minute and your end tidal 2 is, that big. Look at you guys are ready for boards. Look at y'all. Love it. Perfect. All right. Fantastic. All right. Questions on that. I will say really quick about LMAs. Yeah. So PSV Pro. So I will say really quick about, LMAs. So whenever you have an LMA, those of you who don't know what they are a supraglottic airway. So if you have your vocal cords here, the LMA is going to sit on top of the vocal cords. So usually with an LMA, you never want your pressures, your peak pressures to go over 20. Because what happens is once your pressures go over 20, you start blowing air into the esophagus, which can cause the stomach to distend and could possibly cause aspiration. Because technically with an LMA, you don't have a secure airway. Never look at an LMA like your airway is secure, right? Because those cords are wide open and the patient could laryngospasm at any point, especially if they're not deep enough. So I love pressure support for my LMAs. I usually stick those in. I leave them apneic a little bit. I build up that CO2 and then I throw them on a little bit of pressure support, less than 20 centimeters of water. If you do, some people, your preceptors could tell you different. Some people do use rocuronium with LMAs. You use 10 or 20 of rock, which is a paralytic. Some people don't do it at all. It freaks them out. If you do have an LMA in and you're comfortable giving a little bit of rock, or the surgeon all of a sudden is like, I need paralytics. And you're like, oh God, no, you don't. But fine. I'll give 10 or 20 of rock with an LMA, and then I will put them on pressure control. So whenever you have an LMA, it's either pressure support or pressure control. Were you going to ask something, Cliff, about PSV? Guys, have any other questions? And we'll talk about, we'll get into the scenario really quick. Any other questions? Awesome. All right, so let's put all of this together really quick. Oh, okay. I thought you had a question. Let's put this together really quick, and then I'm briefly gonna, Cliff had asked me a question yesterday, and we'll talk a little bit about circuits so I can kind of set you guys up to study Mapleson circuits. Gotcha. Thank you. I appreciate it. All right. So if you guys have your PDF, you can see the scenario. If not, I'll tell you guys the scenario really quick. So, because this is literally the case you're going to do over and over and over and see over and over and over again. So, 65-year-old male. He's 127 kilos. He's got COPD, not on home oxygen. He's still smoking. He's got a couple stents in his heart from some CAD, high blood pressure. He's had kidney stones in the past. He's on some inhalers, a beta blocker, baby aspirin, which he did stop. And he's been had surgery before with no problems. What ASA would you guys give this guy? What would you say? And he's going under to have a robotic prostatectomy. Anybody want to guess? 1, 2, 3, 4, 5. 3. Perfection. Yep, I'd make him a 3. If he was on HOMO 2, or his, coronary artery disease was not really controlled, wasn't taking medications, I'd make him a 4. But yeah, definitely a 3. So we're going to take his prostate out, and he's going to be in steep T-Berg, which means legit his head is going to be damn near on the floor, and his, if he's going to be in lithotomy, and his feet are going to be up. I don't know if you guys have done any of these, but depending on the surgeon, this can take 3, 4, 5, 6, 8 hours. I've had some take an entire shift to do these. So sometimes ventilation can be challenging. So in terms of this patient, what are we thinking about his FRC? Is his FRC at baseline going to be good, or is it going to be decreased. Remember, your FRC is your reserve, the reserve. So his FRC is going to be down. Yes, correct. What about resistance? Increased or decreased resistance for him? Under anesthesia, flipped on his head, in steep T-work. He's probably got a big belly. Yes, good. So decreased FRC, and then his resistance is going to be increased. And what about his compliance? Yep. Very nice. Very nice. You guys are so smart. So good. Decreased FRC, increased resistance, and he's actually going to have decreased compliance. All right. And also he's a good job. And also he's a smoker. So you're going to be, nice job, guys. You're going to be worried about airway reactivity. So anytime you have a smoker, a COPD, or an asthmatic, they have reactive airways. You want to get them super deep before you tube them or put an LMA in. They're always at risk for laryngo or bronchospasm. And I usually give them a little albuterol pre-op. And then sometimes I'll give it in the middle of the case, and sometimes I'll do it on wake up as well. Yes. And if you guys have seen it before, it's like literally legit. I've had a couple laryngospasm experiences, and they are not fun at all. So keep these patients like that deep, okay? And then when you wake this guy up, I would suggest to maximize his FRC, I would suggest putting the head of the bed up a little bit to maximize that, waking him up on some pressure support. You want a patient like this with a reactive airway, yeah, no bueno, no fun. You want a patient like this with a reactive airway who's bigger. You want to make sure his CO2 is in a really good spot before you pull that tube, and you want them really, really awake. And those of you who don't know, when you're waking someone up from anesthesia and they start to furrow their brow or grimace, that's telling you that their brainstem is back. And that means you're well on the way of getting that patient awake and popping that tube out. All right, let's go through this really quick. So you ramped this patient up, you tubed him, you had no problems, his vital signs are all stable. And so now we put him on volume AF mode because I love it, it's the best. So let's say we put him on a 650 tidal volume, respiratory rate of 12. I'm going to start his respiratory rate kind of high because we're going to have a pneumoperitoneum, and I'm have all that CO2 circulating around. I'm actually going to knock his end tidal down to the 30s as low as I can, because I know that he's going to soak up that CO2 and retain it, especially because this case could literally last 8 hours. I'm going to give him a little PEEP at 4 centimeters of water. I like PEEP a little bit. And then I'll titrate his end tidal, like I said, in the 30s, and I'll try to keep his peak pressures to no more than 30 to 35. I'll pipe in a little bit of air, and I'll keep his sats 95%. That'll make me happy. All right, so it's been 3 hours. Now your peak pressure is in the 40s. His sats are 88, 89, 90%, hanging out in there. His end tidal CO2 is creeping up to 52. So now what? So now what are we starting to think? Obviously, this isn't this talk, but obviously you're always going to think big guns: pulmonary edema, pulmonary embolism, pneumothorax, pneumomediastinum. You're always going to think the big bad things, but we're not going to talk about that here. This is in general, what are you going to be thinking about when you see sats dropping, end tidals going up, peak pressures are low? We probably have another 4 hours left, Lord knows. Absolutely, yep. When was the last dose of paralytics? Is he coming back breathing? Are you seeing those Carrari clefts on the thing? So is he coming back breathing? Does he need a little bit more rocuronium? Perfect, Jack. Yes. Recruitment breath. Beautiful. And I'll explain recruitment to you guys in a second if you don't know what that is. Is your circuit or is something kinked somewhere? Sometimes, something is kinked or gets wedged, especially with those robot cases you're pushed up, against. Always look at the surgical field too. What is happening on the surgical field, right? So my always rule of thumb is if I start seeing some crazy stuff, look at your surgical field, look at your patient, and then work your way backwards to your machine and see what's going on. Other things that you can do to try to fix that. So you've given them some paralytic. You can turn up your FiO2. You can turn off the air and just roll them on 100% oxygen. is there maybe a mucus plug, suction down the ET tube. You can give some albuterol as well. Maybe he's bronchospasming a little bit. You can deepen him up, give him some fentanyl, increase your gas, give him some albuterol. And then obviously your volatile agents, your Stevo, your DES, those are bronchodilators. And then alveolar recruitment. So this is like the Valsalva remover for the maneuver. What did I say? Valsalva maneuver for those of you who don't know. So there's a couple ways to recruit alveoli. Some people, you can turn your PEEP up to like 20 to 25 for like 30 seconds and do that. I don't have patience for that. I just take them off the vent. I turn my APL valve to about 40 to 50, and then I squeeze the crap out of that anesthesia bag for about 5 to 10 seconds, and I do that 3 times. And what that's going to do is that's going to pop open those alveoli, and it can start picking up oxygen, and you can increase those sats. So that's what I do. That's also called the Valsalva maneuver. Surgeons will ask you for that. So turn off the vent. Turn your APL valve up to about 40, 50 or so pressure and squeeze that bag. Now, initially, when you do alveolar recruitment, your sats are actually going to drop. So you're actually going to see a drop in them, and you're going to be like, oh my God, oh crap. It's fine. They're going to pop right back up. Happens every time. And you can also increase your oxygen flows as well while you're doing recruitment breaths. Anybody else do any type of things for alveolar recruitment? That's what I normally do. Sorry, I'm so thirsty. And then if you want to get, super sexy with your preceptors, when you're talking about alveolar recruitment, what are you actually doing? You're increasing the transpulmonary pressure aimed at opening the alveoli, and you're improving compliance. So that's actually what recruitment breaths are doing. Increasing transpulmonary pressure, opening alveoli, and you're improving compliance of the lung. All right. So after all those things that you're going to be running through and doing, you fixed him, right? Your sats are 95 to 96%. And if you were with me yesterday, what did I say? The enemy to good is better. So if his sats are 95, 96, we don't need them to be 100. Let it go. It's all good. Peak pressures are trending down 29, 30. We can live with that. We expect them to be a little bit on the high side. And our end tidal CO2 is now in the 40s, right? Questions on any of that, and then we'll talk about Bain circuits really quick. You guys are awesome. You guys can teach this. You guys are rock stars. All right, so I'm not going to go too deep into this. I just will give you like a little bit of an overview. This is more of like a visual thing. So I told Cliff that I will, in the next couple weeks, I'll do like my normal weekly teaching. We'll talk about Mapleson circuits. I had this like preceptor like way back in the day. We called him MacGyver because he would always be making these crazy apparatuses, and he'd be like, what Mapleson is this? And I'd be like, I don't know. It's not something you're going to come across a lot when you're in clinical practice, but it is something you might get asked about at clinical, and obviously the boards like crazy stuff like that. So when you're delivering anesthesia, you have your breathing circuit, right? And that circuit is delivering volatile agents in O2, and it's removing CO2. Now, there's 4 types of breathing circuits. There's open, which is like your nasal cannula and your face mask. There's no reservoir, and there's no rebreathing. There's no dead space there. Then you have your semi-open. I know they're painful. They're super painful. Like I said, I'm going to come up with something to make these kind of easier to remember. I'm just going to do a brief overview today, but I'll see if I can dig up my old board study notes, because I'm like, I never really had a good handle on these in school. So the second one is your semi-open, and that's where these Mapleson circuits come in. So they have a reservoir and there's no rebreathing. Then you have your semi-closed system, and then you have your closed system. But the Mapleson A through F are your semi-open systems, right? So there's tons of great pictures of these online, but it's pretty much like an apparatus where you can pipe in some fresh gas flow, to remove the exhaled CO2. And what they usually consist of is some type of face mask. Some of them have a reservoir bag. You usually have some type of like corrugated tubing. You have the fresh gas flow inlets. You can get the gas in, and then some type of expiratory valve or APL type valve. So So that's kind of an overview of those. I'll see if I can find, like I said, my old notes and see if I can find like a fun way to remember them, because I remember I think I know I'm really good at boards. and then after that, I really don't see them, like as being a CRNA working in practice. I really don't see those a lot or do much with them. But the main thing is they're semi-open. They have a reservoir. There is no rebreathing. I know one of the board's questions they like to ask is which ones are the best for controlled ventilation. So if you want to write this down, it's DFE is greater than BC is greater than A. Because A is the best for spontaneous ventilation, but that is the order for the best for controlled ventilation. So in order again, the best circuits for controlled ventilation is DFE, BC, and then A. Yep, and then the semi-closed is the circle system. And that's where we get partial rebreathing and a lot of dead space. Gotta love this stuff, guys. Some of this stuff you really won't see again, which is like kind of nice because it, makes you crazy. So questions about anything I went through, you guys like freaking did amazing. That was like a brief overview. There's so much more stuff. Eventually we can talk about PEEP, CPAP, BiPAP. We can go way, way deeper into the ventilator as well. I just wanted to give you guys some like tips that I use and do. Do you guys have any other questions? I'm going to make a really quick announcement and then I will let you guys get back to your evenings. I think I hear my baby crying. Any questions, guys, on anything? I appreciate you guys hanging out with me. I'm kind of like in my basement right now. Yes, it's in the email. You should have got it. I sent out an email like a half hour before this started. So message me if you didn't get it. I also put a link in my IG as well. So yes, that is there. And it's pretty thanks to my business partner, made it pretty for me. All right, so really quick, I'm going to tell you guys about something I'm going to start doing. Thank you, Megan. I appreciate it. I've been an SRNA before. Now I'm a working CRNA and a mom and wearing tons of hats. And I know being in your position is hard, right? Balancing your time and understanding all the information and retaining it, and then like getting beat up in clinical and anxiety and the papers and the papers and papers. And I heard a lot of you guys say that it would be, it'd be nice to have like a mentor or somebody to kind of help you through that's been through it or whatever. And I'm going to tell you guys what, I've like been there. Like I remember sitting in the OR crying in the mornings before the cases would start, sitting in my car crying, not wanting to get out and just being like broke and having personal issues and et cetera, et cetera. And it's hard. So what I'm going to start doing is I have a lot of stuff coming down the pipe. I'm releasing a free clinical guidebook to help with some clinical stuff next week. I'm going to be hosting a masterclass on the brachial plexus. I've got the brachial plexus down to like one sheet of paper. So I'm going to walk you guys through that. I have tons of stuff in the pipeline, but to give people a head start if they need any extra help, I'm always going to be available on Facebook, IG, giving you guys free stuff, taking care of you. But for any of you guys that want to go deeper, if you want to go a little extra, if you need help now with anything, I'm going to start doing mentorship calls and kind of mentorship sessions with you guys. Everything will be confidential. We can talk about, we can go over your personal statement. We can go over, interview practice for CRNA school or jobs. I can tell you about my S-Corp, my 1099, etc. And through the rest of the week, I'm going to be offering mentorship sessions for $17 for 30 minutes. And I believe $37 for an hour, and then I'll increase the price later. But I just want you guys to, like I said, I'm going to be here giving you guys free stuff all the time, taking care of you, giving you advice, whatever. But I do want to make myself available if any of you guys do want to go deeper and want extra help, or if you need to vent, or you want to study for boards. I can teach you what I did for boards. I can study with you. I can quiz you. We can chat about personal struggles and all kinds of things. As I'm telling you, I've definitely been through it. So that is my announcement. I will, one of you guys that were either there yesterday or today, I will enter you guys in to win a free 30-minute session with me on whatever topic you like. I'm happy to, and then on these, if you want to talk about a certain topic, I'll be sharing my notes with you and my stuff. So this is kind of like a head start. I'm going to have, like I said, a lot of stuff coming in the pipe that I think is going to be super helpful for you guys, but I want to make myself available to you now while I'm creating everything. So that's it. So I hope you guys are excited. I hope you guys learned something today. Did you guys learn anything new today? I know most of you guys are like, awesome, know your stuff, which is good. I remember the vent was just always so like daunting to me. So you guys learn anything? Type anything in if you learned something new. I want you guys to like impress your preceptors. That's why I'm here. I want you to like drop some knowledge bombs on them and look good. And then I think in the next few weeks I have information. I'm going to do these Mapleson circuits. We'll see if we can get you guys an easy way to remember it. I'll go review my notes. I'm talking about musculoskeletal diseases and anesthesia. And then I believe I'm going to talk to you guys about, assist flow. Fantastic. Yeah. If you see it anywhere, use it, or just talk to your preceptor about it so you can look awesome. I'll be talking about musculoskeletal diseases. I work in a plastics office tomorrow. I did some endo work, so I'm going to, do some teaching on some plastics office stuff and working endoscopy. So that's kind of like the next 4 weeks. I will have this brachial plexus masterclass up soon. I'm going to be having some board study tools for you guys coming hopefully by the end of August. So those are all the exciting things that are coming down the pipe that I'm working on. Your favorite vent setting. Oh, great, Megan. Great. Perfect. Well, good. I'm glad you guys can learn something new. That's why I'm here. If you guys have any questions, any topics you guys want to know more of, please let me know. That's why I'm here. Like I said, I appreciate Clifford giving me that one. I was like, oh, that's a good one. I'll have to do a week teaching on that. So let me know. I will have the information up for the mentorship sessions. I will email that out. I will also have links up and posts up on Facebook and IG either tonight or tomorrow. So I'll have all that information. I'm happy to mentor you guys, and I'm also happy to be here doing this. We'll do some more fun free classes, and let me know what I can help you guys learn. All right, and I'll give you more PDFs and more great stuff. Anything else, guys, before we go that you guys can think of? I appreciate you guys hanging out with me. I got kicked down to my basement because I got 20 people running around upstairs in my house. Always. Anything else? Make sure I didn't miss any questions here. Awesome. You are so welcome. Thank you guys. Thank you guys so much for trusting me with your time. It's super, super appreciated. So, all right. Well, thank you. Look for an email from me if you haven't signed up yet. I'm going to take all that stuff down tonight. So if you haven't signed up, let me know. Megan, I think I have your email anyways. So get signed up if you haven't yet. I'll get all the information to you. And I hope to see you on Facebook. I hope to see you on Instagram. And I'm happy and here to mentor you as well if you need me. All right? So have a wonderful night. Go get some dinner. Study hard. Get some sleep. I'm going to try to sleep too. And I'll be posting some stuff for my day. I'll be doing plastic surgery. I think I'm doing like boob jobs and rhinoplasties tomorrow at an office that I've never been to. So wish me luck. Janae, there is a link on the Facebook page to sign up so I can get your email and I can get you all kinds of fun, awesome stuff. So it's probably like about a few posts down for now, a few posts down from this one. So yes, and you just click on the link and then you can just enter your email in and I'll get you some stuff. So I know, fun. Hopefully, I think the surgeons are good though, so hopefully I should be okay, but I've never worked there before, so this should be interesting. So you guys can come hang out with me tomorrow on Instagram stories as I navigate this new plastic surgery office and learn some new stuff. So, all right, you guys, thank you so much. Have an awesome evening. I appreciate your time. I know it is limited. I get it. I've been there, and I will be in touch and talk to you guys very soon. All right. Bye, guys. Thank you.